There we go. Good afternoon. I'm Ann Phibbs, Director of Education in the Office for Equity and Diversity. Welcome to The Price of Healing, Diversity Issues in Wellness, Health, and Healthcare, the sixth of 7 conversations that make up the Office for Equity and Diversity's critical conversations about diversity and justice. I want to point out we have a flyer for the last one of the semester, or rather of the academic year, the animal-human connection, clarifying the roles of service, emotional support, and service animals. I might have read that wrong. Clarifying the roles of service, emotional support, and therapy animals, which is April 17th, so pretty close here. So I invite you to that as well. The Critical Conversation Series is co-sponsored by the University Libraries. My colleague Jody Gray from the Libraries is responsible for creating a list of further academic resources on each of our Critical Conversation topics, which you can link to on our Critical Conversations webpage. This is our 3rd year of offering these conversations. I'm excited to say that we're in the process of planning our 4th year right now. We're excited to continue offering live streaming so that you can watch via the website in real time or at a later date, since they will be archived in our Critical Conversations webpage. And I was sharing with our moderator and panelists that this particular topic is the topic I've gotten the most phone calls and emails from people, primarily practitioners outside of the University of Minnesota. So I'm hoping that a good number of them are checking in with us via live streaming right now. We've also added an opportunity for you to provide feedback on this series. If you've signed in, we'll email you a link to an online evaluation, or you may access that link on our webpage. And as with all conversations, we'll start with some discussion among our panelists and moderator, and then move out to you all in the audience for some Q&A. I'm excited now to introduce the moderator, my colleague from down the hall in the Office for Equity and Diversity. Dr. Danica Scott serves as Assistant Vice Provost for Equity and Diversity and is responsible for facilitating the development and implementation of senior academic leaders' mission-driven strategic equity and diversity goals, and for partnering with campuses, colleges, departments, and programs to create and execute efficient, effective, and integrated equity and diversity evaluation strategies. No wonder she's so busy. I don't see her that much. It's an important job. Dr. Scott is also an assistant professor in the Department of Pharmaceutical Care and Health Systems in the College of Pharmacy. Her primary areas of research are understanding student experiences and success indicators, spanning the continuum from pre-pharmacy to graduation, with a particular emphasis on access, retention, and progression of underrepresented students, and uncovering the role practitioner implicit and explicit biases may contribute to ongoing disparate healthcare outcomes for minoritized populations. Dr. Scott completed her Doctor of Pharmacy and her master's degree in higher and post-secondary education at the University of Michigan, and is completing a doctoral degree in organizational leadership, policy, and development at University of Minnesota. We're very lucky to have her in the Office for Equity and Diversity. Please welcome Dr. Danica Scott.
Good afternoon, everyone, and I'm thankful and grateful to be able to moderate this really important session. We have a fantastic panel of experts that are waiting to begin the discussion, so I won't take up much time initially because we can get to actually listening to what they have to say based on our questions and your questions. So our program today, if you've had the opportunity to read it, is really is couched in the following. The U.S. spends the greatest amount of GDP on health care per capita among the most advanced countries, yet ranks 46th in the world regarding most efficient health care. So in our conversation today, we will examine healthcare research and treatment disparities while also exploring cultural knowledge and practices that communities use to maintain health. So with that, I would like to have the panel introduce themselves and first tell us a little bit about what they do and how in the work that they do. So if we can start with you.
Good afternoon. I'm Rhonda Jones Webb, and I'm a professor in the Division of Epidemiology and Community Health in the School of Public Health here. I also co-chair our School of Public Health Disparities Work Group along with Kathleen Call. And one of the missions of that group is to advance health disparities research locally and nationally. Just very briefly, my research focuses on alcohol use and problems, particularly in the African American population. And then I also focus on adoption, implementation, and evaluation of alcohol policies.
I have my very own mic. I'm Atum Azahir, and I am founder and executive director for the Cultural Wellness Center in Minneapolis. We came into existence in 1996 after 2 years of thinking with and sitting on porches and doorsteps and around tables asking people like myself the question around infant mortality, which keeps coming up. Why do so many African American children, babies, not live beyond the age of 1, the first year? And people had posed that question to me for a long time because I have spent a lot of time working in either nonprofit organizations, places where we were organizing to improve health or housing or something of that nature. And so when the question came to me, and the challenge actually came to me, I decided that I didn't want to know why babies died. I wanted to know why they live. I want to know why my son, who is now 55, born when I was, do the math, the day after I turned 16, I was 15 on August 9th in 1959, and he was born on August 10th. So what I wanted to know is, why did he live? What was it? What were the indicators, factors, features of my life? Considering that I had not graduated from high school, that I did smoke, and other things, as you can tell, but my baby lived, and I wanted to know why that was. What I learned is that my mother, grandmother, great-grandmother, and all the people around who are responsible for him said that if I was convinced that I wanted to be a woman and a mother, that they were going to hold me to that. And in holding me to it, it meant they were going to be accountable, not just for my future development, but the development of my children. So now I have 4 sons, and they all are really alive, and one died, but that was after, when he was 48. So that wellness center is dedicated to their life, their living, and the systems that kept them alive in spite of all the other things that's going on.
Good afternoon. I'm Patricia Park. I'm the Executive Director for the Minnesota Indian Women's Resource Center. On July 1st, we will celebrate our 30th year as a all-around holistic approach to serving the Native American community in the urban setting. So we are a full-service agency. We have housing, we have mental health services, we have a chemical dependency program, we do life skills, we do parenting, we work with families involved with child protection, and we work with families trying to prevent child protection. And our interest in this is, from a cultural standpoint, our community can't heal unless culture plays a strong role. And so we implement mind-body medicine techniques along with traditional teachings and using ceremony and medicines. We use traditional mental health modules, but we add smudging and ceremony to that as well. We refer to it as a blood memory. And so within our community, unless you connect to what is blood memory, things that have been passed on from generation to generation to generation, you can't be successful in addressing health problems. And for our community, along with the African American, we fight for top on the worst lists of everything. So highest levels of cancer, highest levels of chemical abuse, highest levels of whatever. And so we're really at a point now with the information coming out as far as social determinants of health, as far as adverse childhood experiences. And for us, we feel that finally science is catching up and explaining why our community has struggled for so long, as we have dealt with over 500 years of colonization in this country. So I'm honored to be here. Thank you.
Good morning. Oh, good afternoon. It's not the morning anymore. Somewhere it is the morning. So good morning to you all. My name is Dylan Flunker. I'm from Rainbow Health Initiative. I'm extremely honored to join this panel. I am the Research and Policy Manager at Rainbow Health. Rainbow Health Initiative is an LGBTQ health equity organization. We do advocacy, research, and education around LGBTQ health and health disparities. So my job is sort of twofold. I work on our community-based research, looking at what are the health disparities in the LGBTQ community. And then I also do a youth and young adult health and wellness and tobacco control program that kind of engages youth and young adults where they are at and try to curb the rates of smoking in the LGBTQ community. So,
Great, thank you. So for our first question this afternoon, for nearly every indicator within your individual groups that you're working with and working for, there's disparate health outcomes. And we have used, over the past couple of decades, we've really spent a lot of time really understanding those differences and exploring the ways in which they actually exist. So coming to this understanding that there are disparate health outcomes. So given that, and we spent so much time at that end, really now the question for you is, what do you believe is kind of the etiology, or what are the causes, if we can start with causes as we advance on the causes of the disparate health outcomes from the work that you see and also from the research in your particular areas? So anyone can take it first. We don't have to go round robin. But don't all take it at once. Elder Atum. Mike.
Thank you. Let me first say that a little bit about this whole idea of etiology and research and evidence, that the way we think about life and living is not considered in what you call research. Whether you talk about medical anthropology or any other, it's just not considered. So where we begin is, as I said to you, we want to know why. I want to know, we want to know, why do we live and how do we then further life? And so the theory that we developed after listening to people, we knew we needed to have a theory because many of our colleagues and friends, excuse me, were in the university, and many in our family. You know, I have family members who actually graduated from university, and we have these ongoing discussions about what is knowledge, where does it come from, what is legitimate knowledge, what is knowing, how do I know, and what do I give credit to for what I know. And because that's such an ongoing discussion for us, and certainly for me, I want to start by saying when the intellect is not ready to be ruled by the wisdom of the heart, man is in danger of destruction. And it comes from an African elder. As I move through life, again, I want to always, it's important for you to know that I was born in 1943 in the Delta of Mississippi. And the reason that's important is because people of African heritage, as you know, the conditions under which we have lived, even to this day, cannot, must not be compared to the conditions under which European Americans live. And as a matter of fact, it is that comparison that always looking to where do we go for the standards that really keeps us in many, many cases from living up to our greatest and highest potential. So what we've done is to really say that as I grew up in the Delta, as I look at the people around me, I want to know why my father was able to stand, literally stand, with his head high, with his hand on top of my head, and teach me and transmit to me knowledge that gave me the capacity to again stand, for generations to stand. Why were they able to stand? Well, they were able to stand because at the core of who we are as people of African heritage, at the core is once again this heart, this way of knowing, this intelligence of the heart that gives me the capacity to create, to be with the Creator, to be in creation in a way that even if I'm under amazing hate, duress, being stripped of language and all of that, I can still stand. The thing that we work with is, how do I tap into that? So how I tap into the resiliency, the capacity that my father and mother had for standing under the kind of terrific hatred that they did, and continue to be men and women of honor. So this idea of the heart, the wisdom of the heart, the tapping into a way of being and a way of knowing that takes us beyond and as a matter of fact, one of the types of work that we do at the Cultural Wellness Center is to go before and beyond, because for the African, we have to think about this theory that we created that says individualism, loss of culture, and loss of community is what makes you sick. That's what makes you sick. So if I am standing by myself and I'm pregnant and all I have is $400 or $500 a month, but I'm isolated, I don't know the names of my neighbors. I have food to eat, but it came from McDonald's. I don't know what rituals and ceremonies will ground me and center me, and the core of who I am is not developed. If that is the condition, both inside and outside, that I'm with, my child will die. We know that. So that would be our first point, is to say there is no research currently that can capture the intelligence of the heart, and it's our work then to put that in place. And so that's where we started at the Cultural Wellness Center.
Bettina?
I agree with everything you say. No, I'm just kidding. For my community, one of the problems is there aren't enough of us that people care enough to research us individually. And so it's often research looking at white or brown, so dominant society and everyone else. And that really fails to recognize the different experience of all of the rest of us that we've had. So, for my community, I can't, emphasize enough the importance of what historic trauma really has done to the community, because we have spent 500 years having our land, our identity, our language, our traditions, our cultures, our core being of who we are taken away from us, and oftentimes violently. And so, when you look at history, we are only one generation away from deliberate federal action to tear us apart. Sterilization programs went through the 70s. Our children are being taken away at crazy levels up until the late 70s. So in my lifetime, that's not enough time for any community to heal. And so more effort needs to be, again, at looking for those of us who have thrived and not just survived. What made a difference for us? And for most of it is a strong sense of who we are as a core. So that when we're dealing with poverty and you're dealing with, the stress, the daily stress that creates that toxic environment within your health system, what is it there that helps some people move past that? And despite it, succeed and become successful. And so bringing people to their core identity is something people don't really study. We look at social determinants of health. 40%, they say, of health is related to that. Well, when you are living in constant poverty, if you are living in a state where you don't know where you're going to sleep each night, the stress that causes in your body, unless we address the underlying causes of that stress, nothing about behavior is going to help. You know, you can't tell someone don't smoke if that really is their sole means of a vacation, of getting away, right? As if it's the sole thing they can do. And yes, they know it's unhealthy. That's the other thing. A lot of times these kind of behavior addressing changes presume that people don't know better, that if we're educated, that, you know, eating a certain way, exercising, don't smoke, we'll have better health. Presumes that as a population we're kind of stupid, and that's inherently insulting as well. We do know smoking is bad, you know. Most women know smoking while you're pregnant is not a good thing to do. But there's not enough effort there to get to the underlying causes as to why people engage in these behaviors. It's just all directed at the effect. And without getting to the cause, you really don't do any good at all. And so until people do feel a strong sense of identity and strength and who they are so they can stand tall and strong, that toxic environment is just, you know, just tears apart a person's soul and their body. And so, yeah, as long as that exists, my people will constantly be the highest cancer experiencing, the highest, you know, name your health disparity. We're on the top of it. But also it's because we have highest levels of poverty and just inability to really find success. So you can't have a health discussion unless you also talk about those realities that these families are working and dealing with daily.
I just want to kind of echo kind of similar comment around just the role that socioeconomic factors can play in explaining both one end of the spectrum, wellness, as well as inequalities in health. And just maybe give a couple of examples from my own research. Some of my early research really tried to get at the question of why particularly African American men reported greater drinking consequences than their white counterpart at similar levels of drinking. So people are drinking at similar levels, but why does one group experience more problems than the other? And so we looked at the role that neighborhood poverty played in explaining those differences. And we found that the drinking consequences were greater only among black men who lived in basically poor or impoverished neighborhoods. We didn't find those disparities among black and white men who lived in more affluent neighborhoods. And it just suggests that where we live basically influences our health. And then just a second example from my research, we all know that homicide rates are very high, particularly among African American men and Hispanic men. And again, you know, why do these disparities exist? And so we looked at the role of kind of neighborhood characteristics, socioeconomic neighborhood characteristics in explaining some of those differences. For example, neighborhood educational attainment, neighborhood income. And then we looked at the racial neighborhood composition and homicide rates. And once you took into account these socioeconomic neighborhood characteristics, those differences were markedly reduced. Again, just showing that these broader social and environmental factors really play a key role in explaining some of the disparities that we see.
Thank you.
I think one of the unique things about the lesbian, gay, bisexual, and transgender community is that, you know, prior to my own identity and also like perceptions, like not all LGBTQ people are white, and so
Yeah.
okay. And so one of the things that we bear in mind when we're doing our work is that we know that the experience even within the community says low battery.
Grab the other one.
So even within lesbian, gay, bisexual, and transgender communities, people come from all sorts of racial and ethnic backgrounds. And as my fellow panelists have eloquently stated, like there's a lot of historical, social impacts on people's health that are racial and ethnic based. We also see that there's, impacts to people's health because of their sexual orientation and their gender identity. And so for us, our work really tries to maintain that broader focus of we're not just narrowing in on someone's sexual orientation separate from their race or their income, because all of those things are going to impact someone's health and wellness. And how do we stop slicing people up into these tiny little identity slivers when you're not seeing the whole picture? And so that's really, I think, the biggest challenge, and also like my greatest joy in the work that I do is trying to make sure that we're maintaining that broad lens that looks at all aspects of identity that are going to impact someone's health and outcomes. There are certainly, when you start looking at LGBTQ people versus heterosexual or cisgender is a word for someone who's not transgender. When we look at LGBTQ people, we do see disparities, but I don't always know that it's as useful to just narrow in on percentages and statistics. It's valuable to know the disparities, but people's stories and lived experiences are honestly just more important. And how can we get to a place where everyone is living and thriving, and we're talking about what makes people live full lives instead of how do we not have people dying. I think right now, at least in LGBTQ communities, one of the biggest things is the health of our transgender community, our sub-community within the broader LGBTQ community. And some of the challenges there around research are just that there hasn't been a lot of medical research on the impact of transition. What does it mean to take hormones? What does it mean to have surgery? And what does that mean for your long-term health? And how all of those things are impacted by someone's income or race and background. Those are just not studied at all, and I think definitely an area that we need to look at for the community's health.
Mm-hmm. Great, thank you. Patina, you touched on it a little bit in your answer, and really a lot of this initial work has actually transpired, but then it comes down to, so what do we do about it? How do we affect change? What are some of the things that, and important steps and action plans that we should take as a society really to advance the work, whether it's politically, socially, personally, professionally? We have a lot of health professionals in the audience and online. So if you guys could touch upon and talk a little bit about what you see as action steps to try to ameliorate the disparities that we see. Patina?
Okay. Got called out, huh? Well, I think from the perspective of the healthcare providers, taking a hard look at yourselves and recognizing any bias that you may in fact have. Because racism does play a role. There's a judgment oftentimes when people come to receive health care that might not be intentional, but it is interpreted very strongly by the population who's receiving it. And so to do some just kind of self-reflection, I think would help. Partnering with agencies who do serve that population to help you learn how to work better. Just because everyone is suffering from cancer does not make them the same at all. Their treatment plans may be similar, but even within that, there should be differences that are targeted to the individual that you're working with. And if you don't have an opportunity to really know who you're working with, then you're really not serving their full health needs. You're just serving the disease. And that's, I don't think, going to be very effective, particularly with my community. Pushing, for a living wage, pushing for affordable housing, pushing towards a change in that 40% of social determinants of health would be a really big start if you really want to see a change in disparities. Because for people who are living in that kind of environment, getting health care is not high up on their priority list. They're on the lower tier of Maslow's, right, pyramid, right? They're surviving. And there's a misconception, too, as far as in the Native American community, that we all get free health care through Indian Health Services. That's not accurate. And Indian Health Services, most of the time, they have to refer to specialists who won't see you without insurance. So there's barriers there as well. And just, I've was impressed. I'm going to call her out here because, I see some from Children's Healthcare. They've taken some steps as far as getting a Native American liaison within the hospital to help with people who are coming. Because when you're part of a dominant society, you don't recognize the power of seeing someone who looks like you when you go somewhere to receive some kind of service. Someone who's there who knows the system, who can explain it to you in a way that you understand. Having those kind of liaisons can be very helpful as well, and is a simple fix as far as just budgeting for the position. But then also, reaching out to agencies. We're looking at partnering with children in different ways so that we can serve children from Native American communities in a more appropriate way. Having the ability to reach out and ask for help, to take advice, which within the medical field, before I did this, I used to work in the medical field. I know, doctors have worked very hard to become knowledgeable in what they're doing. And sometimes having them recognize that they don't know everything about something is hard, or they don't have time to do it. And so, taking that step to ask and to ask community what they need rather than telling us what we need is another strong thing to do. Because I know my community, I won't speak for anybody else, but there have been oodles of people who have decided what would be best for us and have come at us with their savior mentality, and it never works because we weren't involved in the discussion as far as what we think works best for us. And, encouraging minority attendant, if you have more Native American doctors and hospital, staff, so that when people walk in, they see their community around them, that will encourage attendance within the health system too. I know that's harder because we also, lead the rate in dropouts and a failure to go to college. But a lot of that, too, has to go to social determinants of health. Mm-hmm. And so we can do a lot to improve disparity if we start looking at it outside of health and more of how are people living and how can we make them live in a better, healthy way.
If we're going to start talking about providers, I think that is really accurate that providers need to be willing to acknowledge when they don't know something and examine bias. There's lots of types of bias that people can walk into the waiting room with, into the clinic room with. I think for looking when you're looking at even how medical records are set up, if you're even looking at how those systems start to screen things out, they're not set up in ways that are helpful for real people that have complex lives and identities. A great example would be that you can't get coded in medical records unless your clinic has a workaround. If you're a transgender person, it's really hard to get coded appropriately so that what your body needs for care is reflected in your medical chart. So if you're a transgender woman who goes into a clinic and you are in need of a prostate exam still, because you still have a prostate, but you're coded as a woman and they're not able to check that care, they're not able to bill it to your insurance, they're not able to even know that it's something that you need to have done on the regular. And so I think even just taking steps back to look at how our systems are set up and how our systems treat people is very important to improving care for folks. There are lots of horror stories. I'm sure everyone on this panel has heard horror stories of people interacting with doctors. I'm sure all of you have horror stories. I think that really looking for providers to examine their own God complexes a little bit. It's a Friday afternoon. I'm getting wild. But just, I think re-examine that you've worked very hard. You have a lot of knowledge, but you are not perfect. You do not know everything. And that, I think that would, and being able to acknowledge that you are situated in a particular identity, that you don't know everything. You don't know about everybody else's life. Being willing to come and ask questions, and be open to what do you need, what is healthy for, what is your definition of healthy even? What do you need to live a full and well life? And being able to listen to people in communities when they're giving that answer. And I mean, even, being willing to learn. I've had friends that have had to pull out their own catheters because nurses wouldn't touch their bodies. So I think there's just a lot of basic information about looking at people as and being able to see them as whole people and see all of them and not erasing parts of their identities.
Rhonda?
Well, I'll kind of represent the public health perspective, and public health really focuses on population health. How do we improve the quality of life in communities? And I think because the causes of health inequities are due to multiple factors, I think addressing those inequities will require intervening at multiple levels. So dealing with things like affordable housing, jobs, safe neighborhoods. In essence, I think there's a need for a very comprehensive approach that addresses multiple areas of influence in our lives. I think it's very important that as we kind of think about solutions, that we engage those individuals that are most affected by the problems, so that we work in very meaningful ways with communities to really understand problems that are important to them, and more importantly, the solutions that they see as important. And then forming partnerships with communities, engaging them, and from all the way from definition of the problem to how that problem gets evaluated. So just basically taking a approach that I think really engages communities from the very start.
Okay.
I appreciate what each of you have said, and I want to suggest also that the point for the work that we're doing is that the knowledge you use for what to do is going to keep getting you what you got. And that there has to be a very different knowledge system that will produce health. I mean, what I hear us talking about, we are really preoccupied by, is sickness and disease. And once again, sickness and disease is a direct result of conditions in a society that does not value life. And so we have to think about the good life. We have to think about whether or not the very system of thinking that can start with spirituality and think about thinking. So we suggest that we start with this point earlier that I tried to make about research. What is the knowledge base that we start from? At this point in time, it is very, very hard for me to see and hear so much emphasis on comparing a condition of African Americans, of black people, to white people. It is very, very not helpful. It's not helpful to have a disparity formula that says that health is where you see European Americans at this point. I know many wealthy European Americans, many, who are looking for meaning, who are trying to find a formula right now for connecting back to a way of being and knowing that will give us a different kind of practice. If you think about how did other healing positions come into existence, I would ask that you think for a moment about healing positions. What are some of the ones that you know about that are not physicians and nurses in a quote-unquote healthcare system? Healthcare delivery and some of the ways that it's being delivered is going to continue to be delivered that way unless we start over. I mean, and I know that's it's kind of idealistic and philosophically it is suggesting something that may not seem possible, but we have to start the shamanic tradition, for example. Let's think about the ways that we now are trying to go to herbal, remedies. What are some of the ways that we're trying to go to curanderos? What about, you can name some. Even as I think about what's happening with massage therapy and acupuncture, what is happening is massage therapy, acupuncture, and the other touch professions are now being done by physicians, or people are really training to do better at being an elder than I can be because I lived a long time and because I've been a part of, everything is professionalized and coming from a system and a core knowledge base that takes us back to where we are now. We keep going around and around in circles for that. So my suggestion, again, is for us to think about the knowledge system that is in place now. That is, as we think about it, we talk about object, rationality, science, and technology. So if you objectify everything, technology is obviously the solution for it. And I know in a house of scholarship that possibly somebody else should be talking about this, but let me tell you, what scholarship is for us is how do I learn from the pain and suffering that I've done that gives me increasing knowledge about how will I use my pain and suffering, turn it into knowledge, and do something different with it. And my vision then becomes spirituality, not technology. So if technology is the solution, then we're going to continue to really have a technological interaction that you and I can have, whether you are a physician or a next-door neighbor. So what I'm hoping for is that together we can create, again, a source of knowledge that in the first place doesn't start with the intellect. Once again, it starts from the heart. So how do I know what I know? What is it that gives me the capacity to interact with you as a human being? How do I get from who I am now after all I have endured as a people? Not as an individual, but as a people. How can I stand in front of you as a European, not to compare myself to you, but to say, you know what? I have the capacity to love, think with you about where we're going to go in the future. That takes a whole new knowledge system. It takes a new kind of way of knowing and being that has to be at this point in time documented, yes, but the documentation systems will also have to be considered differently. One of the documents that I was going to bring was really by Sean Wilson, who is actually a Native man, who talks about ceremony is research. Research is ceremony. Or someone else in the African tradition who talks about story. And everyone is using story now, right? But what about the story of how creation came into being, and how do we take a creation story, add it to what is a life practice, add it to what I'm doing right now as I get off track to help me to get back on track. So I just want to suggest that knowledge is a problem right now. The type of knowledge, the source of knowledge, the objectification of everything, and technology, as the end result of everything and the perfected state of everything is a problem And the problem that we're struggling with will continue to be reproduced unless we get to the point where we can start with some form of spiritual knowledge that gets to wisdom, the core of wisdom, the core of creation, the core of how do we know based on, again, a way of being in the world with all of life. That is really a place that we are not there, and we need to get back there.
Mm-hmm. Thank you. We have varied perspectives on the panel, and so now I would like to open up the question and answer period from you guys with the remainder of the time that we have.
So if you all will share that one.
Mm-hmm.
Okay.
So any questions?
Could you do me a favor and just run down your names once more? I didn't write them down. I want to be able to address you when I ask questions.
Rhonda?
Rhonda?
Patum.
Patum?
Patina.
Patina? Thank you.
Do you have a question you want to start with?
You want to start?
Well, someone else certainly could.
Okay.
Thank you.
Patina, Tiffany Beckman here. I really enjoyed what you had to say. It was very refreshing. And actually, I enjoyed what each and every one of you said. I think it brings a whole new perspective to health and healing, and I value that. And I'm really glad that you said that. And I think we have a lot to learn from what you've said, and I hope that there are others in this room that take care of patients. Anyway, I don't want to take up all the time, so I want to give this to somebody else.
A gentleman.
We'll go here and then.
So I'm a retired physician, and I'll probably come up with several questions as we go along here. But the first one that comes to me is you're all very human, and you probably go to your providers with very human needs. But I think you have to realize the position that providers are in now. Providers are being controlled by insurance companies that want efficiency. They want things technologically to click. They want to put diseases in distinct categories so they can be dealt with in kind of a tree-like fashion of cause and effect and cure. So I guess one thing that we all have to do is go to our providers with a message of, here's what I need from you as a human being. I don't need a computer. I don't need a thought process that's just very precise and logical. I need a thinking, feeling being who understands me. Insurance companies aren't very interested in having their doctors understand their patients anymore. That takes too much time. That's too inefficient. They want a diagnosis, they want a category, they want a solution. So do you have any thoughts about that? I'm afraid that the direction you want to go in and the direction that insurance companies and providers are going in are kind of two different directions. Any thoughts?
Can you pass with Mike?
I recognize insurance companies create a whole dynamic that is unpleasant because they're a business. They're there to make money. I briefly did insurance defense as an attorney, so I get it. But I think, even under the Affordable Care Act, insurance companies have been directed to work and target those populations that they haven't. I can tell you as a Native American woman who operates an agency, I have not had a single insurance company reach out to me, with the exception of Blue Cross Blue Shield, who brought us their marketing information to see how their marketing information was received within the Native community. Our first note was, there are no Native people on any of your pictures. You've got brown, but they're kind of an indistinctive brown, and so that's not going to really relate to us. That, and it was the package like this, and it's like, if I live out of my car, that doesn't mean anything to me. So, I hope there'll be some change, but you can also try to pull yourself out of all the stress and don't let the insurance company dictate who you are as a person. We do billing because we do mental health, and we manipulate those codes. They fit, but we also serve our clients. So yes, they may be a post-traumatic stress disorder diagnosis, but it doesn't mean we don't also smudge. We don't also give them opportunity to have healing touch or mind-body medicine techniques. The doctor or the therapist isn't doing it, but our agency is. And so we can create a holistic approach because we also approach it as community. One person doesn't have all the knowledge. You can't. It's impossible. You need people to really approach any kind of health problem in an individual as a community, because community is kind of what got us in the health conditions that we are. And so we'll see, those insurance companies, man, they need to be here. They need to hear this too, because if we did really approach people as people, you'd have better outcomes. You'd have less disease, and they'd spend less money. I mean, that's just the truth.
I was listening earlier and heard a group of physicians, something has just happened with Medicare reimbursement, just like a day or so ago. Is there something that changed in the law that allows physicians now to be reimbursed at possibly a higher
The yearly change so that we don't get claimed for Medicare. It happens every year for us.
Right. So I started to think about this question and realized that one of the suggestions that we now are beginning to have with our physicians is to show that if you work with me as an elder, you possibly can reach what the insurance company is requiring you to do quicker and even better. Because if you partner with, once again, with an elder, and physicians are having a really hard time thinking that they might be learn something and benefit in some way from partnering. But if the physician, the elder, the person who is the next door neighbor, all took a look, my aunts and uncles and people, if we all were looking at what is my role, I think you might get more efficiency, which is what the insurance company is looking for, than you get now. So my suggestion is not to necessarily look at the insurance company first, but to look at how we, once again, have acquiesced to what the insurance company is requiring of you as a physician, and to once again think through what is it that the community person, as I said before, all the resources in the community could do to once again help you meet that. And I think that what we're seeing is that all of us would be better off if we partnered in a different way from, again, the point of view, as you said, of a human being, and not something that's higher than or driven by the insurance company.
Mm-hmm.
Thank you very much. I really enjoyed the panel. I just wanted to say that I wanted to share that about the issue about biases. I think one of the things in the health system, and I think I want to emphasize the fact that the workforce needs to be diversified. And right now I'm working with doctors from over 60 different countries that are medical doctors that are passing the exams in this country and not getting to medical residency to be able to diversify the workforce. And as you say, a doctor and patient, if there's some concordance in, whether they understand each other's culture, they understand their language, you will have a better outcome. And I also wanted to emphasize the fact that health is not, you think about health as a more comprehensive factor, not just whether you're sick and go to the doctor. If you don't have social and environmental factors that boost everybody's health, you will always have disparities. It's not the doctor that will prevent disparities. I think it's the whole community, the services, the nutrition, the environmental sanitation, the education right in the schools about kids understanding health, understanding about their bodies, and being more productive citizens. And also, one of the things I think is important is to include spirituality. We are more than just physical being. And Elder Atum was talking about it, that we got to think more holistically and spiritually as we look at health. Thank you.
Who had a hand up? So I just want to.
Okay.
Thank you. Thank you for your clear understanding of one size doesn't fit all in particular. One area of diversity that I think gets overlooked are older Americans. And we assume that they're taken care of, and we assume that they're taken care of one way. I'm curious, from your perspectives within your various communities, how older people are being treated and how their sort of the externalization of treatment is forced on them that is not concordant with where they are and where the community is. And one other point is just the aspect of aging in community, as opposed to having to go into a silo or another type of institution, or only aging in place, which is death in a lot of ways for people as well. So what types of things are the communities doing to recognize older people's health needs and their spiritual and sense of community that you're not seeing matched in the larger system?
Well, I am an older. And one thing that recently happened, once again, this is from a provider, North Point Health and Wellness, who the organization is really rethinking very seriously this whole idea of care and how care is going to be consistent with, again, people's views of themselves, especially cultural views and values. And so what recently happened is that a healthcare home, people know this idea of a healthcare home, so they've been certified as a healthcare home. And what that means is that the people in positions actually treat you as if they're family members. And so this idea of a family member who is going to work with me as an elder, as an old person, who does nothing that doctors tell me to do. I mean, literally nothing. So, and at the same time, continue to go and ask for advice. I mean, I don't know if you know this, but one thing about as you get older, you keep on asking, well, what should I do? And the reason you ask for what should I do is just to see if what the other person is going to say, not because you intend to, you have no intentions, of doing anything they tell you, but you just want to see, what they're going to say. So here's what happened. This healthcare home idea, people now act like they're part of my family. So my husband and I get a phone call, and the woman on the other end says, what are you all doing? So I say to her, well, what do you think I'm doing? She said, I think you're over there, she always accuses me of working too much, staying up too late. That's what I think. So what are you doing? So I said to her, well, you're right. So she said, okay, here's what we're going to do. And we go through this whole thing of planning on the phone as if she is my cousin or my mother or my daughter. And then the final thing they're doing is seeing my husband and I together. We have a doctor's appointment with the primary care physician together in the same room at the same time. And they ask me about him and him about me. The physician is doing this, okay? And then, again, the nurse is making a recording because she says the minute we walk out the door, we'll change our mind about whatever it was we said we were going to do. So this is a healthcare home model. It is a model where they are looking at what are the cultural practices, values, language, What are the beliefs? So we don't end up in collision of beliefs. And they're carrying it out once again in the healthcare home, and it really is working better. And again, back again to what did the research say about healthcare homes, and what are the things that we now know about how important it is to partner with and to be kind of in harmony or in friendship with the people who are receiving and also giving the care.
I think for the LGBT community, it's especially heartbreaking sometimes because people end up going back in the closet as they age. And so if their partner or their spouse passes away and they need to go into a care facility, if they are, estranged from their biological family or from their community, if their family became their group of friends that kind of built new family and community, as people age and spouses and friends pass away, people end up really being isolated, both from the families that they were born into and the families that they made. And so figuring out how the LGBTQ community can honor our elders has been really challenging, but also valuable to recognize who was leading the movement in the 60s and 70s, who is still. There's Miss Major is a powerhouse. She was in Stonewall. She is still leading marches and organizing stuff. And I don't understand how she does it because she's got to be 78 or something. So she's amazing. But just honoring our elders and she does more in one day than I think I do in a week, honestly. So so I think honoring our elders but also not just remembering them and talking about them, but also figuring out how are we going to build communities and networks that are supporting people in our communities that are aging. What are we going to build for when we ourselves are aging? How are we working with folks that are younger than us and teaching them to respect people that have gone before them in community? And this is broader than just LGBTQ people talking to other LGBTQ people. It's figuring out a broader sense of community and place and where you live and knowing your neighbors. And that can be really scary for a lot of reasons, especially if you're LGBTQ and you're worried about your neighbor. But that's also, I think, the way that one of the many ways that change happens is when you see your neighbor and as a person, and when you are able to have a conversation and hear a story and not just see them as a statistic or a number. And so I think that's a really interesting point, just that there are lots of lots of different facets of people's life, and that being an elder is one of them. And figuring out how, even in someone who's in their 30s, how do I interact with elders in my community? How do I learn from them? And how do I not just forget that there are all these people that have gone before me that have laid the path, is definitely a challenge beyond health, honestly. And health is certainly part of it. But as our panel has evolved, we really are talking more about community and the wellness and thriving of communities, and less about physical health.
Mm-hmm. Can I make one comment, Ellen, off of what you said, just to point out two things that have happened in the GLBTQ community. One of them is the organization Training to Serve that does training for people in retirement homes. And because there's so much bias around understanding sexual orientation, gender identity differences, and in elderly populations. So that's been a tremendous, they do wonderful work, so I just wanted to point that out. And also Spirit on Lake, which is the first ever in the Twin Cities housing for GLBT folks who are older. And it's on Lake Street. It used to be where Spirit of the Lake Church was, and now Quatrefoil Library, which is the only GLBT lending library, is housed on the first floor. And if you drive by Lake Street, you see a new building with a huge rainbow flag, you'll know that you've found it. But those are some things. Barbara Satin is an amazing activist in the trans activist and GLBTQ activist who's done a lot of work around aging. I just wanted to put those two to institutions out there or
Thank you.
Opportunities.
Hi, I'm a student in political science. So how do you see the role of the state of Minnesota in relation to your work, both current and future?
One more sentence, as my favorite professor used to say. Like, one more sentence.
One more sentence.
Yeah.
So, like,
what do you want to know? More.
How can government support your programs? Or what legislation would you like to see, or even at the local level of governance? How do you interact with it? What do you want in the future to help improve what you're working on?
I'd like to see insurance plans in the state of Minnesota all be required to cover all transition-related care for trans people. That's a huge barrier that we see. I would like to see single-payer health care, but I don't know that we're going to get there anytime soon. But that's my, end desire to, not have a lot of this insurance business nonsense, or less of it. Those are two things that are the top of, if I had a legislative agenda, that's what it would be.
Oh, where do I start? I have state grants, so I'd like to say that I support my state grantors and love them immensely. But one thing I find always frustrating from a policy level is the solution to anything is to create a work group and to spend more time and money doing things to figure out what to do. I was just at the disparity, they're going around the state doing their disparity meetings, and, just a few $1 million has been given to the state to address disparities. And we were asked, where could we focus that money to make the biggest impact? And I believe it was $5 million. My response was, let's spend $5 million actually studying it statewide and see what the actual honest response and how much it will truly cost will be, because that's about how much it would cost to do a study at that level. Instead of giving a 10,000 here, 20,000 there, 120 if you're lucky somewhere else, and even joke or fool yourself that will have any impact on health at all. It only makes those of us who are in the field become cutthroat, instead of working as a community as we all need to, making us fight for a measly $5 million, and you think that's really going to do anything to impact disparity in the state, is ridiculous. It's absolutely ridiculous. And so having less discussion amongst themselves and more discussion with the actual providers, those of us who do it, would be so much more helpful. Less savior mentality and more actual true community partnership, I think, would have a higher impact.
First, I think government has a very important role. There's controversy over whether government should have any role other than, protecting citizens. So I strongly believe government has a role in the general welfare of the population. And probably some of the policy issues that would be most important are around affordable housing, safe and affordable housing. I think early childhood education. And probably a model that really resonates with me is something like the Harlem Children's Zone, which uses basically the schools as a kind of a focal point for dealing with a number of issues that affect families. So the program focuses on provide social services, career counseling, health issues, all within the context of the educational setting, and that to me is a good model to follow.
Mm-hmm. Greg. Yep.
So I want to also thank the panel for a very liberating and honest conversation. My question is coming from the perspective of, I'm a law student who's studying health law, particularly with the justice and equity lens. I'm also a full-time medical writer. And I heard Mother Atum mention something about the knowledge base, the knowledge source that providers are using to inform their care delivery. And I know at one time, maybe a couple of years ago, some hospitals and clinics were performing, and maybe even insurance companies were were on this community-based research kick. It was really hot and sexy at one time. And it sounds like the money's gone away or it's not that interesting anymore. And it sounds like we're really going back to maybe a more hard scientific research model. But I thought that there was some progress being made in some areas of the community where there was community-based research models. And I just wanted to know from some of the community-based workers if that's still happening on the same level, if it's growing, if it's dwindled, if it's that those opportunities for people to tell their stories, for community to organize around healing and research and sharing that knowledge with providers, is that still going on?
Well, you just happened to give us a chance to talk about something quickly. The answer is yes. Community-based participatory research certainly has more credibility now. I think many in the research world would say that this past couple of years we've seen CBPR, get a lot of traction. Mm-hmm. And I think credibility, and I use credibility because we've done just so much thinking about research. And community-based participatory research or action research, which we all kind of like better, is certainly still being, matter of fact, growing. So quite a few people in the room, that's where I know many people in this room from. But something that I think is really powerful that's happening is that not just in Minnesota or at the Cultural Wellness Center, but we're thinking through how do we create and develop a culturally and community-based institutional review board. That I want to get to this idea that research, even if it relates to policies, research and the knowledge production process that's in the academy has, and I'm going to use somebody else's words from an article, really become insular and distant from the actual life experiences and the story. And so with that distance has come many of the solutions that people are implementing and investing in. So with the Institution Review Board and really thinking through how will cultural people, what kind of standards of review might there be that really does take into consideration the idea of spirituality, the idea of the cosmos and value and all of that. How would that look if it was a standard for reviewing the research projects that are coming, whether it's in community-based participatory research or the double-blind, whatever that's called. So I think it's happening and it's growing. So community groups, cultural people are beginning to say knowledge is the problem. Let's add other sources of knowledge, other knowledge systems, as I said, and put in place in the Institutional Review Board, as well as what we're doing now and trying to do, an ethics board that would look at research from a very different point of view and hold it to a different standard. So some of us are really working hard to make that happen. And so the answer to your question is yes, and I think it's getting stronger. And I think the researchers could speak to that even better. But it is getting stronger because community people are saying, I know something. And doggone it, I'm going to express what I know, and you need to value what I know. Because as a part of the solution, it is a different way of knowing that's going to give us the variety of ways that we all need to put together in order to get a solution that really takes all of that into consideration.
Hi, thank you very much for sharing. I just have a question. In your respective organizations, have you guys had the opportunity to work with community health workers in your organizations, CHWs? No, and I'm just wondering what your experiences have been, and if that's a workable sort of structure going forward. I know there's some federal funding allocated, especially through the healthcare homes, like North Point, and I'm just wondering what your experiences have been and if that's like a workable structure, I guess, going forward.
I think it depends on the organization that community health workers are sourced out of. In my experience, is that you can have a community health worker, and even if it's someone that's if you have like an LGBTQ identified community health worker based out of some clinic, speaking specifically to the LGBTQ community at least, if their structure still is not set up in a way that is understanding of like the realities of someone's life, then it's not gonna work very well. And I'm imagining that that is replicated in other communities as well.
Yeah, and specifically, I think you mentioned that there's an American Indian community liaison in children's, and it would be somebody from the community. Typically, is the ideal candidate who lives and works in the community. And you said you had worked with them at North Point. And has that been a helpful experience, or for other people in that clinic setting?
I think, once again, the community health worker, to the best of their ability, do make a difference. And they do help, because you're right, they are from the community. They usually speak the language. And so the short answer is yes, they do help. And we would not want to see them go away.
Great. Craig?
I'm Craig Hassel. I'm a faculty member over on St. Paul campus in the Department of Food Science and Nutrition. I'm also a Cultural Wellness Center fellow and have been studying with Elder Atum down in South Minneapolis for over 10 years. I wanted to bring squarely to our awareness the obvious point that this institution that we're in is an institution about knowledge, about education and knowledge production. And the Cultural Wellness Center is also a knowledge production organization. And as a faculty member, I've chosen to use my academic freedom to spend significant time down in the Cultural Wellness Center attempting to understand the community's system of knowledge production as best I can as a trained academic professional. And part of what that helps me is to understand the cultural foundations of my biomedical training, because we don't talk about our training as culturally based. We don't present our biomedical concepts, our medical understandings, our physiology, our biochemistry as cultural constructions, but they are. They come out of Europe very clearly and have roots all the way through back to ancient Greece. But we don't understand that cultural dimension is invisible. And because it's invisible, it's very hard for us to interact and to interface, again, a Cultural Wellness Center term, interface with people who bring other knowledge systems when we don't understand the cultural foundations of our own knowledge system. That immediately creates an asymmetry that makes it very hard for us to understand what other cultures have to offer and the knowledge systems that they bring. And as someone in food and nutrition, I have come to understand over the past years how much has been lost in these older non-biomedical knowledge traditions, that we've made tremendous progress in our trajectory of advancement, but we've also lost an incredible amount. And to be able to look back and see what has been lost as we have pursued our project of progress, modernization, and objectification And we have to understand what knowledge assets exist in communities. It's very, very difficult to do that without spending time in community, interfacing and interacting so that I can then find a different vantage point from which to look back at myself and back at my own training. And that is what has been so valuable for me. Thank you.
Thank you. There's one in the back.
I want to thank you all for sharing your experiences. I'd like to tap in like the gentleman who asked about the elderly population, and mental health population was also named by the Minnesota Department of Health. And I'm sure all of you have lots of experience with that. It cuts across all populations and age groups. And I'd like to know how you experience that with the providers. What are some of the high points of what really makes it work well, and then what are the low points or obstacles where we can do better? And then secondly, how do you engage the broader community? Because my feeling is that coming out of the tradition that's within the provider system, it really is just the individual. The family is where the individual goes for follow-up care, but how do you get information from many sources in the feedback loop of the evaluation of how things are progressing?
Well, our agency, there's nothing we do that's not trauma-informed. So that's our housing, that's life skills, that's parenting, that's our co-occurring disorder chemical dependency program, because the trauma experience is so prevalent within our community. So it's fairly easy for us, based on the fact that there's situational diagnosis with mental illness, to pretty much diagnose everyone. So it's less about, having that formal diagnosis then. It's more about helping the people who are experiencing it and their family to understand the behavior that has been exhibited because of their experience. And recognizing too just the historical component, it was really exciting for me to start seeing that there is, epigenetics and genetic research on what trauma does to a population, and that there is an impact on future generations. Because that to me gave like a satisfaction of, yes, we know, we've lived it for hundreds of years now. And so it gave some validity to our experience as well. And so for us, we avoid mental health or mental diagnosis. We try to look at it more as what does an individual need to really succeed, and a lot of that is dealing with toxic stress. And, from children, we're trying to develop children's mental health now that have a cultural perspective, because, we had a early child care program that we had to close last year because of funding. And so, we know there's a huge gap there, and we know that our kids average 7 to 8 ACE score in just their day-to-day experience. So the mental health kind of conditions are prevalent from the beginning because of the situation, mostly, those, again, social determinants of health, not due to any experience, a personally driven one. And so not focusing on it being a mental health problem, but more as how do you address the behavior caused from it? And the mental health diagnosis is really just for us a funding stream. It gives us the code we need to send in to get reimbursed, But as far as we're concerned, if you come to me because you have experienced extensive sexual violence in your life, or if you've come to me because you've been homeless and lived on the streets and participated in survival sex, it doesn't matter to us if you come to us because you want a domestic violent kind of relationship. We don't care so much what it was that brought you there. It's more about what do you need to heal, and across populations it's very similar. The treatment isn't different, really. It's coming from getting community support and a sense of self and a sense of self-strength. Those are things that help people heal. And for a lot of our population, we're over-medicated too. And so, even within our CD program, as people have started to heal, they've cut those medications, in half and then again in half until they're barely taking anything.
So the question was, how are you billing for it?
Well, we have a wonderful relationship with the Fond du Lac Band of Lake Superior, Chippewa, so we bill through them at the federal all-inclusive rate. So I access federal funds with my mental health diagnosis, but even if we use Medicaid or whatever, I'm a nonprofit, so I use other funding to support elders and community work and massage and acupuncture and everything else. So I don't rely on a sole insurance payment for our services. You can't survive that way.
I think this is. I just want to tell you a quick story. Yesterday, we work in schools, and we do not, under any circumstances, do reimbursements. We have made a conscious decision that the work we do is really going to be elders and community people, and as I said, family systems. It's kind of the language that I think is familiar to you. But yesterday in a school in St. Paul, this is an elementary school, and what we've noticed in our work in the schools is that the children are, we don't even know how to describe the pain, the amazing rage that 7, 8, 9, 10-year-old children are experiencing and expressing. And because we don't know how to, it's just totally incomprehensible to us that a child that young could have that much rage. So what we've now begun to do is to think about ways so that the school staff, whether it's the teacher or the behavioral specialist, that we are have begun to try to find a way for us to be, us as elders and community members, to be in the school and to be present. And it's so this young boy is 9 years old, had an incident on the playground that was just threw him, as they say, tripping, and he was just off the chain. There are 3 large professional people, 2 men and a woman, who are around this child and holding the child down. And this kind of holding and is probably, I believe, taught that you hold in a particular way, but nonetheless you hold. Our response is that further irritates this young black child. They have all these people holding them down. So what we wanted to say is, let us do this. Let the elders come in and let us just stand and watch how just our presence causes a de-escalation. And as soon as one of us can touch and without words and hold, not, there's a different kind of holding, and to watch the de-escalation and to watch the not just the de-escalation for the child, but for anyone else who is in the space. That is the way we want to promote our work with not mental illness, once again, but mental health. Health as in embracing and holding and touching and transmitting and transferring a certain caring that we think comes from culture, it comes from community, and it comes from family. And so we really want to, and that is not going to be reimbursable. It's simply not. So we have to accept the fact that it's not going to be reimbursable. And if there's any aspect of it that is reimbursable so that the professionals can team with us, then we would like to promote that. But at this point, we haven't figured that part out. But we have figured out that de-escalation can happen with touching and caring. We haven't figured out, though, how to partner with people who would get paid for it.
Great. Well, thank you for your questions, for your participation today. I am looking at the clock, and we are definitely out of time. I just want to just say how fortunate enough I think we are to be in this room today, to listen to the different stories, perspectives, such nuanced approaches, and just very different approach to how we can improve health and wellness. And for that, I thank you for coming, and thank the panel again for your experience, your expertise, and for leading our discussions today. Thank you for a great conversation.